Good afternoon and welcome everyone to today's Hopkins Hour online seminar. I'm Tamara Ownsworth and I'm the Research Director at the Hopkins Centre, and it's my pleasure to chair today's seminar. I'd like to extend a warm welcome to all Hopkins members and our partners and collaborators. Thank you for joining us today. Before we begin, I'd like to acknowledge the traditional custodians of the land on which we meet. My office is on the land of the Yagara and Turrbal people. I'd like to pay my respects to elders past, present and emerging, and extend that respect to all Aboriginal and Torres Strait Island people. Today's online seminar will include 3 presentations and a panel discussion on the topic of self-advocacy and dignity. Research on self-advocacy and dignity is a cornerstone of the Hopkins Centre, and we embed this focus across all of our projects, aiming to support people to understand and express their rights and choices in their care and their lifestyle. We also strive to find ways to promote people's dignified participation in activities and life roles through mechanisms of support, user-centred technology, and inclusive environments. I will soon be handing over to our first speakers, Dr. Jessie Mitchell and Dr. Annalie Bates, who will be presenting on the Hopkins Centre Research Project, Understanding What Self-Advocacy Means After Brain Injury, Having a Say in Your Care and Rehabilitation. And their project is funded by the Metro South Health Research Support Scheme and the Motor Accident Insurance Commission. After that presentation, we will hear from Duncan from Spinal Life Australia, who will share some details about what they've developed in terms of a program for supporting self-advocacy as well as resources to support Spinal Life Australia members. Our third presentation is by Dr. Kelsey Chapman, who will be presenting on some of the outcomes on her very recently completed PhD and rehabilitation study, which led to the co-design of a model of dignity in rehabilitation with a focus on what mainstream systems and services can do to increase dignified outcomes. For our panel discussion a little later today, we'll also be welcoming Belinda Adams, who is the recipient of a Medal of the Order of Australia for her service to community health, and Belinda will bring a lived experience perspective to the discussion. We also welcome Claire Morgan from the Acquired Brain Injury Outreach Service for the panel. So before we get things underway, I just want to cover some housekeeping items. We are aware that the internet connections will vary in this online environment. So if you experience technical difficulties, please feel free to put a question in the chat via the toolbar at the top of your screen. One of our events team will do their best to assist you. You can also leave the Teams platform anytime and return to it without losing your place. For those of you who are hearing impaired, we have real-time captioning available via the URL link that our events team are putting in the chat now. And this was also sent to you in this morning's email. So we're really keen to hear from the audience or the people attending. So do feel free to pop questions at any time in the chat throughout today's event. If we have time, I will provide the opportunity for at least a question after each presentation, but we will otherwise ensure that we record your questions for later, particularly for the Q&A session after the panel. And if you prefer to raise your hand to ask the question, if you're having some difficulty with the Q&A function, I'll be keeping an eye out for raised hands as well. And if we don't get the opportunity to answer all your questions today, we will follow up with an email. Okay, so without further ado, I'd like to hand over to Jessie and Annalie for their presentation on understanding what self-advocacy means after brain injury, having a say in your care and rehabilitation. Thanks, Jessie and Annalie.
Thanks so much, Tamara. So like Tamara mentioned, we'd like to present to you about a project that we recently completed that looked at enablers and barriers to having a say in care and rehabilitation after an ABI from the perspective of individuals and their family members. And as Tamara mentioned, we're fortunate to have funding from the Motor Vehicle Insurance Commission and Metro South Health through a co-funded collaboration grant. And we're supported by a large and very diverse team of researchers, clinicians, and people with lived experience of brain injury. So to give you some kind of background and the aims of the project, we know that people who sustain an ABI or an acquired brain injury experience numerous transitions throughout their rehabilitation trajectory, not just after they discharge from hospital, but also in the lead up to that. And these are kind of complicated or made more challenging by cognitive communication challenges and also behavioural changes that influences people's ability to have a say or self-advocate through these transitions. And so what we aimed to do was understand what constitutes effective self-advocacy after a brain injury, and also identify barriers and facilitators to self-advocacy during early care transitions. So particularly in the lead up to a hospital discharge and following discharge. So we conducted semi-structured interviews with 12 participant dyads, 12 people with ABI and 13 of their family members. And so our ABI population came from the Brain Injury Rehabilitation Unit at the Princess Alexandra Hospital and was mainly made up of people who had experienced stroke or TBI, and their family members were commonly spouses or partners, parents, but some kind of next of kin and also children, adult children participating. And so we interviewed those dyads 1 to 2 weeks before discharging from the specialist rehab unit, and then also 4 months post-discharge. And at this time, everyone was living at home in the community, and they'd either transitioned straight from hospital home or they'd gone through interim accommodation or care. And so that first interview was really about the transitions people had experienced up until discharge and planning for discharge, and then what that looked like in the community and how they were able to influence their care and rehabilitation in the community. And so our thematic analysis of the data really reinforced the value of self-advocacy and people's ability to self-advocate after a brain injury. And like as exemplified by that quote, it's so important to people feeling dignified and human, particularly after a brain injury and being in hospital and perhaps feeling like everything has been taken away from them. And they're kind of trying to rediscover who they are and what their life looks like. And so we kind of developed a model of reclaiming agency after brain injury that extended from an initial loss of agency for lots of people through to this kind of ongoing process of striving for agency. And so this is a kind of typical process that we developed that was gradual based on the participants we interviewed, but not everyone went through every stage, and the time that people took to go through those stages was very variable. And I think also important to note that often people kind of reached a stage of striving for agency in environments and systems that they were comfortable with, and then perhaps took a step back as they navigated and became familiar with new systems, environments, and their needs as they changed over time. And we found that agency was influenced by this meeting of capacity and desire post-injury. And it was supported best by what we've called scaffolded support. So this idea that it's important to meet people as family and clinicians where they are at the stage in their journey to support them to advocate in the ways that are important to them. So I'll talk to you a little bit about the stages and how capacity and desire changes over them, and then hand over to Annalie, who will talk about some of those practical strategies to support people to self-advocate post-brain injury based on the findings and her clinical expertise and experience. So that initial loss of agency was really common for people, as you might expect, particularly around post-traumatic amnesia or PTA and kind of those neurocognitive changes around confusion, memory, fatigue, changes in consciousness. And so people really spent a lot of time kind of orientating to time and place and understanding that they had had an injury and that they were in hospital. And so a lot of the decision-making or advocacy fell to family and clinicians at this time, and there was kind of a passive acceptance of that. But then agency kind of began to emerge, particularly as people became more self-aware of their injury and the needs that they had in the current time and place. So their need for care and rehabilitation, and that influenced their kind of growing self-confidence or capacity to ask questions about the care that they were receiving, why they were receiving it, and also start to express what their personal preferences were. And so that's that kind of desire to start having a say in things. But still at this stage, particularly as people were unfamiliar with the care environment, if they hadn't had any previous experience with healthcare, they experienced kind of a period in which it took them a while to familiarize themselves with the different systems and services, and that could kind of challenge people's agency at that stage. And then we noticed that people were kind of striving for agency, and we've called it striving because it was kind of an ongoing process as people's needs and goals change over time. But at this time, people really focused on directing not just their current care, but also their future care towards their personal goals, particularly around independence in their personal lives, returning to work and driving. And yet there was an ongoing process, and as needs changed, so did that kind of desire to redirect care and rehabilitation to meet personal goals. So I'll hand over to Annalie, who will talk through some of the strategies that came up in the findings around supporting people at each of those stages.
Thanks, Jessie. I think the easiest way to really look at this is across the continuum of care. And when we look at the continuum of care, we've kind of got the acute, subacute, and then community. And each of those have a transition point for individuals. So when you're looking at the notion of more directive support, that's generally around the transition point of coming from an acute ward maybe into the Baru rehabilitation unit. And so individuals may present as quite confused, disorientated, still be in post-traumatic amnesia. And what participants were really indicating in terms of enabling them to have a voice in their care is for somebody to be able to really sit down with them to get to know them as an individual. So their likes, their dislikes, their family background, what resources they have, and the changes or their perception of what has changed since they had acquired the brain injury. The other things that people really identify as important is that rapport building and that feeling of safety and connection with particularly the clinicians that they're working with. And that is dual in terms of not only the individual with the brain injury, but also the family members who we know in the research are a significant support for people after an acquired brain injury in terms of the success of their rehabilitation and also their recovery. The other thing is, particularly at this point in time when people are feeling really confused, it seems like quite a simple thing to do, but providing a lot of context around why certain, interventions or actions or treatments are being performed, and being able to continually remind and prompt them around that and not just saying it once. And that's obviously because a lot of people with a brain injury also have short-term memory difficulties, and that reduces their anxiety, enables that relationship rapport and the opportunity to feel safe enough to ask questions around their care. The next kind of phase is really when they're in that inpatient rehabilitation, and people identified that it was really important for them when they did ask questions, for those questions not to be minimised and to have a really responsive approach from the treating team so that they could really become informed and start to be involved in the dialogue around their care. And one of the things that they identified as very critical to that is to having a key point of contact. So in our unit, it is the social work team that tends to be the key point of contact for individuals and families to allow for that dissemination of information, but also a clear communication pathway to ensure that it's a collaborative approach around any care decisions. The other one that we come to is around that next transition point, which is really moving from an inpatient setting out into the community. And that's where people are really starting to have a lot more voice, a better understanding around their own capabilities and what is manageable for them. And they start to have a bit of more of a dialogue around setting their own personal goals. They're feeling more capable and confident in being able to ask the team questions and being able to self-identify that. And I guess, some role modelling from clinicians as well in terms of problem solving, so that if a situation or action event occurs again, they've then got a tool of resources that they can draw on if need be, as well as education to the families around what is needed and the scaffolding that they can provide to the person, particularly once they move from the hospital environment into the community, and where to go for support if they need it. And the final one is kind of the implications and impact. So we know that people first seek to understand, then question, and then ultimately direct their care. And I guess there's scope for clinicians and family members and advocates to really initiate this process in developing people's capacity to create agency for themselves in their early recovery. So I think that for the majority of clinicians probably listening, it might be a little bit 101, some of those practical strategies, but I think that it's also really validating to know that what we do is effective. So I'm going to hand over to Ross, who is our next speaker today.
Thank you very much, Jessie and Annalie. That was a very good presentation. It's the first time I've attended the Hopkins Hour. I've seen them come and go and always wish that I would attend, but that was an excellent presentation. And it segues really well with Spinal Life Australia and our efforts in this area. So our organisation was established 62 years ago to help people with spinal cord injury and other physical disabilities live equitable, empowered and accessible lives. And at the core of that is dignity. And at the core of helping people find dignity is a sense of resilience and a sense of reclaiming agency, I think, as Jessie and Annalie put it. And so we do a lot of work to help people understand what their new normal could look like, to access resources and tools and advice and guidance on every step of their journey. So being a absolute non-clinical setting, we deal with people on the whole range of their life journey after they've acquired a spinal cord injury, for instance. So our peer support team interacts with people who have only recently sustained an injury, and what self-advocacy looks like for that person and their family is entirely different to someone who's had their injury for 20, 30 years. And so our agency tries to help understand from those people at what area of their journey are they in, and how do we best support them, not only to access individual supports and overcome individual obstacles, but to try and really help them, as you put it, reclaim their agency, their sense of self and their sense of ability to achieve in different areas of their life. So our advocacy efforts and everything we do are underpinned by the person's interpretation or the person's aspirations, rather than us aspiring to turn everyone into a Paralympian, for instance. It's more about meeting the people where they are in their journey and understanding how they would like to proceed, and really actively drawing out from them, we could do this for you, but we don't need to. We will do this with you. And so we try and encourage people to take the very first, make the very first efforts to understand, can they advocate for themselves? And if they had to advocate for themselves, what would that look like? So we have done a lot of workshops around the state for people who are 3 months out of the spinal injuries unit right through to 25 years post-injury, to understand what self-advocacy looks like for them, using real-world examples in their local communities, working through how to be a better self-advocate workshop that we've run in many areas of Queensland and in Western Australia, to understand how we help them on the journey to advocate for themselves. So we will advocate with them. If they're not quite ready to advocate for themselves, we then say, well, let us coach you, let us do it with you side by side. And then ultimately we'll do it for you if we have to. And then we'll show you how we did it and overcome it, and try and transfer some of those skills to you as you become more confident through the process of advocating for this one issue. More than that, though, reclaiming a sense of dignity and a sense of resilience and a sense of influence and importance in the community goes beyond solving your individual problem in some instances, can be amplifying your advocacy outcome. So we've helped people through processes of a sense of frustration in buying tickets for a stadium-based event or a music festival. They come away extremely frustrated and upset with the outcome of not being able to buy tickets. So we coach them through about so how you think you would resolve this for yourself, and how do you think other people are feeling about this. And in instances like that, when people are ready, we actually coach them along about, well, if you wanted to try and leave a legacy for everyone else to prevent them from feeling this way, how do you think you would overcome that? How do you think you would change the system, so to speak? And so from a single complaint, not being able to get tickets to a music concert, through to a human rights or anti-discrimination commission case where we've convinced one of the largest ticketing operators in Australia to change their entire system. And their ticketing purchase process now is the same whether you've got a disability or not. It was designed exactly for this person, with this person's direct influence to that multinational ticketing agency. And it doesn't happen overnight. It's a sense of coaching and drawing that person into what potentially could be the next aspect of their journey, or the next sense of reclaiming their agency, a real turning point for them confidence-wise. And there's numerous cases of that. Now, not everyone's going to be an advocate, obviously, but our role as an organisation and not-for-profit in this area, we are entirely passionate about advocacy. We will help people overcome their individual issues. We will do it with them. We will do it for them if ultimately have to, but we will try and amplify that and encourage them to amplify their efforts to effect positive change in Australia wherever we can. So the sense of self and the sense of reclaiming agency is extremely important. And it's not even a linear journey. There's ups and downs in the early days of post-spinal cord injury, for instance, but at any stage of anyone's life, they might be faced with a relationship breakdown, a mental health episode, or some other familial change that disrupts their sense of self, disrupts their sense of, I've got a smooth or relatively smooth new trajectory out there. And it's at those points that we come in and try and support that person to regain, again, their sense of agency, regain their understanding about sense of self, sense of influence, and sense of importance to themselves and others in the community. So it's something our organisation is extremely passionate about, that if you teach a person to advocate for themselves, you set them on a different trajectory to achieve in a whole range of areas of their lives. So it's critical to people who are ready to learn about how to be a better self-advocate, that we've got templates for letters to the local member of parliament right through to the state politician, or how to change legislation. Go away, knock yourself out, come back to us for advice, guidance. We'll hook you up with a lawyer if you want some legal advice. So at any point in anyone's journey, we try and be an agency they can reflect to, or they can seek guidance from, or they can say, I'm tired, I've had a disruption, please help, please step in and help me do this. And I think it's an, like I said, an entirely non-clinical setting, people across their whole range of life journeys and various experiences in that. But the research effort that you've just explained there, Annalie and Jessie, it resonates extremely well across people's life out in the community once they're there. It's about dignity. It's about showing people that if you want to aspire and if you want to regain and a sense of achievement, there's agencies like ours and others that will support you to build your skills and really generate a sense of achievement in various areas. And we do place a lot of emphasis on that. It's life as you imagine it. It's not life as we imagine it for you. We'll connect you with our peer support team. You can talk through what their experience was like and maybe reflect on, is your experience going to be different? It has been different. Really personalize your understanding of other people's experiences and how that might translate into, can I advocate for myself? And if so, how do I do that? And how do I translate that across to other areas of my life? So we have toolkits and resources and letters, and we hold monthly meetings across the state. We do Zoom meetings. We participate in administrative appeal tribunal hearings and support people through QCAT hearings when we need to. But again, it's about the ongoing coaching and belief that people can build their ability once they have a sense of resilience and a sense of wanting to reclaim agency in their lives. So it's an important role for our organisation to play, and we're trying to improve our skills in it whenever we can. That's about it for me. And I'm sorry, it was rather informal and not associated with some very cool slides, but we tend to speak from the heart and not be as organised as other Hopkins partners, I think. So I'd like to hand, sorry, Tamara.
No, sorry, I just noticed that we have a question, Ross. I'm not sure if it's for yourself or Annalie and Jessie, but I just thought I'd be a little cheeky and break things up and have a question before we hear from Kelsey. Thank you, Ross. That was so tremendous. And it's really refreshing to hear someone just talk from the heart rather than using slides, which academics tend to cling to. So thank you so much for your very passionate presentation on your approach at Spinal Life Australia.
I think perhaps academics are more organised than I am. So.
There's strengths and weaknesses of that. But I'd like to invite Nina, who's had her hand up very patiently, to ask a question at this point. Nina, you there?
Yes, I am. And thank you so much, everyone so far who's presented. I'm a person with a lived experience of an ABI, and I'm very interested in where rebuilding your identity sits in. I think it certainly works well with advocating. You've got to understand who that new person is, and then being able to understand what your needs are, because in a lot of cases, these are shifting, extreme shifts that typically wouldn't happen under any other circumstance. So where do you feel reconstructing a sense of identity or supporting someone in doing that sits?
Who would like to take that one? Jessie?
We'll give it a start, but please, Russ, chip in, because I think there's probably a similar kind of process that happens post-SCI as well. Nina, you're so right in terms of that kind of people talk a lot about what a new normal is or who I am post-injury and rediscovering that. And I think if I was to map it onto that kind of model or process that we created through this study, I think it falls in that kind of, it comes along with self-advocacy, and so that when it's emerging, people are kind of getting a better understanding of who they are now and what their needs are now, and then when they're kind of striving for agency, that kind of striving for mapping on what you want with what your current strengths are and needs are, and kind of mapping those two together to discover what it is, who you are now and what it is that you want out of life post-injury. And I think that was really apparent in our data. And I think that changed, people kind of went through that cycle a couple of times. So maybe who people thought that they were as they were planning to discharge from hospital, when we revisited them 4 months later, that looked a little bit different once they, people said, I now appreciate some of the things that were being, or the support I received in hospital, because I'm not getting that in the community. And so it's made me rethink what I want or how I want to do things. Does that kind of map on to what you were talking about, Nina, and some of your experiences?
Oh, absolutely. And thank you so much for your response. I really feel that if we explored identity as a separate component on an individual basis, that would, I think, help progress more successful outcomes for people, because it's a very challenging process, and to work with allied health, I think, would be fabulous.
Thanks,
That's
Nina.
such a great point. Thank you, Nina.
Wonderful, and very happy to revisit this discussion at the end of the panel to see how we can build on what we've already kind of gained from Ross and Annalie and Jessie's presentations. But we might now invite Kelsey to present on the Dignity Project and her PhD. Thanks, Ross.
Thanks, Tamara. Thanks, Ross, Annalie and Jessie. It's always such a privilege to be asked to be included in these Hopkins Hours, and I love getting to hear about the amazing work that everyone else is doing. So thank you both for sharing, and I think it resonates really strongly with some of what I'm hoping to speak about today. So similarly to Jessie and Annalie, I am presenting today on behalf of a large team, some of which are pictured on the screen, a mix of academic researchers, citizen scientists, people with lived experience of disability, clinical staff, and together we come to bring all of our shared insights and experiences to do some hopefully meaningful work. A background, just briefly, the word dignity has been used to define the worth and value of people and has historically been used for more than 2,500 years. However, it presents a paradox for the more than 1 billion people globally living with disability, which is, why do some people easily and universally seem to experience dignity and human rights while others are consistently faced with its deprivation and denial? The unequal realization of dignity comes from an increasingly complex societal context where inequalities, institutional discrimination, and historic legacies of oppression all form really pervasive barriers. So even though dignity is used throughout history and in present day, it's embraced by national and international human rights frameworks and frequently used within healthcare, it's a really complex and multifaceted concept, and it's got a variety of legal, ethical, philosophical, and practical applications, which is one of the reasons why we set out to study it. We specifically study dignity because of its upsides. It's proven to provide physical and mental health benefits for people with disability and also for clinical staff. Dignity contributes to increased satisfaction and person-centeredness and delivery of optimal care experiences, and dignified experiences and outcomes increase feelings of safety, security, control, and well-being. At the Dignity Project, central to our research is citizen science and inclusive research methods, which privilege and prioritize the perspectives of lived experience with disability. We like to say we aren't really discovering anything new, but rather uncovering things that people with disability have long known, and we're just creating space for that to come out. There are a number of projects and studies that sit under the Dignity Project umbrella, so to speak, which includes studies that look at dignified rehabilitation experiences and journeys through healthcare systems during both inpatient and outpatient interactions. We also have a number of studies that look at dignified experiences for people with disability in interaction with community and mainstream systems and services, including public transport and employment. We have a range of other projects, including the Voice of Queenslanders with Disability, which is a statewide citizen science survey that was conducted this year and last year. And all of our studies have dignity at the heart as part of the research questions and aims, with citizen science and inclusive research methods overlaid in mixed method approaches, including interviews, co-design workshops, and surveys. Today, I'm really going to specifically talk about kind of the overarching model that we co-designed as part of one of our studies, and also how that can be applied really specifically within mainstream systems and services. So throughout our range of studies, people with disability define dignity as contingent on really the acknowledgement of their personhood and human rights. Staff, specifically clinical health staff, are really committed to dignified practice, but often felt limited by risk management, task-based care and service, and increasingly high acuity of patients within their own contexts. Overall, most people with disability that we talked to reported dignified care and dignified interactions across mainstream systems and services. However, some undignified experiences were uncovered. In rehabilitation contexts, both staff and patients felt that a uniform or standardized approach to dignified care was required across the continuum. So on the screen now is the co-design model for dignity that we created both as part of my PhD and extended in a rehabilitation inpatient and outpatient study. Dignity, of course, is at the center in the dark blue circle, and it's surrounded by a white band which has acknowledgement of personhood. And that's that primary definition of dignity. There are then 4 key components in teal circles that surround the center point, and those are delivery of human rights, maximize accessibility and inclusion, explicitly address gaps, and create responsive interfaces. And those are really components that mainstream systems and services can embed within their design and delivery of care and customer experiences. Then there's a series of light gray circles, which are the strategic actions that help achieve those key components. I'm going to specifically focus on the ways that mainstream services and systems, including health, can explicitly address gaps. So that's that component in the 6 o'clock position, and create more responsive interfaces, which is the component in the 9 o'clock position for people with disability. So the key component of explicitly addressing gaps is both about understanding and identifying potential gaps in services, access, use, and experience for people with disability. And of course, then rectifying those gaps when possible. But really, when that's not possible, it's about informing people with disability fully about those gaps. Gaps occur in equity, use, access, and in information when interacting with systems and services. And of course, the more complex the system is, the more potential there are for gaps. Explicitly stating that there are gaps can acknowledge personhood and make sure that we're protecting dignity. And it also helps to jumpstart action. There are 2 strategic actions specifically to help achieve this component. First is authentic co-design and partnership. And I think this really builds on a lot of what Ross was saying, that the solutions that are developed through co-design and partnership with people with disability, of course, are more relevant and accessible. Participants called for the use of co-design to explicitly address gaps by ensuring that people with disabilities' needs and preferences are considered and embedded in service delivery and service design. And people need to be embedded throughout all touch points in the system, including identifying the gaps, the design and development of solutions about gaps. And this isn't just from a consumer or citizen role, but also thinking through what that might look like in a staff or professional role. And of course, this requires actively engaging with people in the planning, design, and development of projects. The second strategic action really focuses on transparent, accessible information and communication, which is probably one of our most powerful tools for explicitly addressing gaps. People with disabilities sought information about access, usage, and equity gaps, and that information needed to be known, available, easy to access, and communicated in a variety of accessible formats. Information empowered people to navigate systems independently, feel safe, connected, and autonomous. And it also opened the door for communication to foster trust and ongoing collaboration. Critically, information could support informed decision-making. It was more about stating what the gaps are, because there are gaps and we know that, and then allowing people to choose the way that they may or may not want to engage with the system and navigate those gaps. Accessible information is critically important, including information in easy English or other translated versions and multi-modal forms of communication, so not just written. The other key component of the model, which I'm going to touch on today, is about creating responsive interfaces. System interfaces must be inclusive and responsive to individual circumstances, but that's really challenging, right? Participants in our studies emphasize the importance of flexibility and flexible systemic elements, which included people, policy, the environments, and that these all supported dignity. Responsive system interfaces could be achieved through the validation of individual needs and preferences, through hiring, prioritizing, and building capacity for staff having the capability, opportunity, and motivation to engage with dignity, and through peer support. Respectful, disability-aware attitudes, of course, are critical for creating responsive interfaces. Staff serve as what we call street-level bureaucrats who basically have to implement the policies and procedures created for them with respect and dignity. And staff are put in a really difficult position because they're often facing competing pressures, time and resource pressures, task-based pressures, and other KPIs. So while they might have the capability, and they certainly seem to have the motivation to engage with dignity, they might just not be getting that opportunity. So that really requires a comprehensive approach to consider those complex factors, including the types of language that we use, the values we ascribe to, and how we're demonstrating and providing that opportunity for staff to really engage. And of course, the second is validating individual needs and preferences. Participants wanted staff to actively listen, ask questions, and work collaboratively to firstly ensure that they could express their preferences. And then it was really interesting because people said it's not just demonstrating the understanding and allowing me to express my preferences, but it's also then just explaining for me, if you can't meet those preferences, why? And that was enough to start to create that flexibility and dignity. We've been really lucky to have some great outcomes from our research, beyond the kind of academic outcomes, which are important to academics only. We have had 5 conversation articles, which again really relates to how we're getting the information about our research out there and supporting that kind of transparent, accessible information, making our research accessible and public so that people can start to use that to help them self-advocate. And really, the findings of our research have been taken up within the Department of Transport and Main Roads, who used it to scope out some of their accessibility and inclusion work. And it's informing some ongoing changes and quality improvements within Gold Coast Health and Metro South Health. And of course, the Voice of Queenslanders with Disability is a whole of government approach to collecting better data for people with disability and making sure that the policies and priorities and changes that government are making, specifically in response to the Australia's disability strategy and the DRC recommendations, really are embedded and grounded in those citizen voices. So we're looking forward to seeing what comes to fruition from all of that, but really just continuing to support our partners and our generous funders in making these really critical changes at their system interface and through policy, and really those tangible information outputs to make sure that dignity is ensured and it's not such a paradox anymore, and that it's a consistent experience for people with disability across all life spaces that they interact in. So thank you very much for having me today, and I'm now going to hand back to Tamara.
Thank you very much, Kelsey. I always so enjoy hearing about your fabulous PhD. I think it's one of the most impactful PhDs that I'm really aware of, at least in the disability field. So it's now my pleasure to convene a panel. And so I'm just going to get up the names of the panel members. So you've met some of our panel members already because they're our presenters, but we're going to introduce 2 extra members, so Belinda Adams and Claire Morgan. So if you guys could pop your cameras on, terrific. So we'll go straight into the panel. And what I thought I'd do is be a little bit flexible because we have a large number of people online. So I will get the panel started with a question that I have prepared already. But if we get some really juicy, interesting questions or comments from the audience, I would like to integrate that into the panel discussion. Does that sound okay? So very much encouraging the audience to join our panel discussion by adding questions, and we'll just see how many we're able to cover in the time we have remaining. But the first question I have is, what do dignified interactions and self-advocacy look like in practice? So I'm actually going to encourage Annalie to take this one to begin with, because you intrigued me before, Annalie, when you said that the recommendations that came out of our self-advocacy project were kind of like 101 for clinicians. And I think maybe the theory of person-centred care and the principles of person-centred care definitely ring true there. But what does it actually look like in practice, and how can you do this effectively in practice?
Yeah, Tamara, I think that you make a really good point, and I think Kelsey and Ross also spoke to this in their presentations. And I think that you really start as a clinician where the person's at, and they're actually an expert in themselves. And it really is around actively listening to them, clarifying that you've got a good understanding of what they're asking, not minimizing what they're saying, particularly if they're still confused, disorientated in PTA. You still want to be able to listen and make sure that they feel like they're being heard. I think it's also about that rapport building, and going back to that point right at the start where I spoke about getting to know them, what makes them tick, what makes them an individual, because it's about that relationship that you have with them. And if you've got a really strong rapport and a good relationship, it means that you can work really collaboratively with them, and it's a team. I guess the other thing is it's about sometimes that education and that context. So that information giving, but providing it in a way that is going to be appropriate for where they're at in their recovery, in their rehabilitation, and timing some of that. And then it's about closing that feedback loop, because sometimes I know within my role, and it's something that I'm incredibly passionate about, obviously, but you are a voice sometimes for those individuals that are not yet able to have that voice on their own, and you're walking alongside them. And so being able to go back to them and close that communication loop in terms of what their questions were. And so I think that's what it kind of looks like in practice. And when you kind of talk out loud, it sounds really, really simple, but it's very, very impactful. And certainly that's the feedback that I've received from both family members and patients over time.
Thanks, Annalie. It kind of brings true with what Ross said before, that if people aren't in a position to advocate, then you may need to actually advocate for them as a stepping stone to then supporting and coaching them to develop the self-advocacy skills, and then handing it over so that people actually take the driving seat themselves. But early on in ABI recovery, that's possibly not realistic for many people, but having people around them that are prepared to relinquish and fade that support and encourage the person and empower them to step into that role for themselves. That sounds like a really important principle. So I might move on to the next question then. How do you create space and opportunity for dignity and self-advocacy? So I might ask Claire to respond to this one. So in a busy clinical world, how do you create time and space for self-advocacy and dignity?
It'd help if I turn my microphone on, I think, wouldn't it? I think for me, it's preparation and education. So creating space and time is really important. And well, I guess first of all, ABIOS or our team, we're in the community, and so it's always nice to validate. And when you are referred a new client, you can tell how much effort, and we appreciate how much effort is put in to creating that sort of sense of self-advocacy very early on in their rehabilitation journey. So it does help us sort of when we are in the community down the track to do that. But I guess creating space is, and I guess I come from it also from a speech pathology background also, that I use really clinical strategies of with, you know, our clients have a moderate to severe cognitive impairment up there with their brain injury, and so it's coming at it from a communication specific perspective as well. And and delivering information to people that's accessible to them, like in a multimodal way. So it's augmenting anything that you might deliver verbally with written information, for example, and providing summaries of information, and like Annalie touched on earlier, like doing clarification and repetition. So creating sort of a more even playing field and even space for people with brain injury is something that I do often. Yeah, I think it's also another point that I wanted to make was creating and sitting where and meeting people, and Ross has also touched on this, is being patient and meeting people with where they're at in their journey at that point in time. And Abios, we work with people, sometimes a year or 6 months or a year post-injury, but we can also be referred people 10 years post-injury, because we have that sort of model of care which is really inclusive. So it's being adaptable and flexible to meet everyone where they're at that point. Yeah.
Thanks, Claire. I'd like to now invite Belinda to have some input, because there's a particular topic I think Belinda would like to speak to, and that's, I suppose, some of the challenges and as well as possible strategies for supporting self-advocacy for people who've been out of the system for quite some time and perhaps aren't still linked in or may never have been linked in with specialist brain injury services. So, Belinda, what does that look like from your perspective, some of the challenges of self-advocacy?
I'd say the biggest challenge is actually being believed. So even in my experience with my son, we've had a doctor, when we were trying to apply for NDIS, tell us that just because he had a brain injury doesn't mean he has one now. So through the interactions we've had throughout this process, it's completely disempowered my son to believe he can advocate for himself at all. And as a carer, it's quite difficult to be taken seriously also, because you don't have a medical degree or any kind of formal background that, some services will listen to. And so I feel that there's a whole cohort of people that want to engage with services that now exist that didn't exist then. They don't have reports, they don't have current assessments that are required. Those can be quite expensive to obtain. But even the process of trying to navigate the system of applying, I've found difficult, and I don't have a brain injury. So for a person who has never been in the system or long out of the system, I don't know how they would navigate that themselves.
Belinda, have you found any sources of support from advocacy organisations?
So I have called. I had an appointment with Carers Queensland. I was given a number of services to connect with. Dylan doesn't fit into any of the boxes that I've called thus far.
Yeah.
And I think because he wasn't expected to survive. He was in a coma. He had to learn to walk, talk and eat again. But he has, worked so hard to regain the level of independence that he has, that I feel it almost goes against him. And so I also think another thing we really need to look at is the idea that people have to be severely impacted in order to access services, because if we can give people a little bit of help and they can retain that independence, their employment, good working relationships, because with everything he has to deal with, he does an incredible job. And I'm trying to do everything, but I worry that one day I won't be here. And if I can't access some kind of support for him, that's my fears for the future. So, yeah.
Thanks, Belinda. And we're just getting some comments coming through. I'll just say the most recent one, because that directly speaks to what you've shared, Belinda. So we have a comment: simply terrifying, Belinda. Let's hope a definitive diagnostic test is available soon. It's not just diagnosis, it's long-term sufferers we need to capture and assist. So I understand what you're saying. People who are functioning at a certain level, despite having had a catastrophic injury, that process of rebuilding independence can often mean that they're not considered to have sufficient level of disability to access support, and they kind of fall through the cracks.
I also think it's the stressors in their life. So, you know, Dylan's been through a lot of life changes. He's separated from his partner and he's navigating care for the children and working full time. And so, you know, the challenges seem to have increased, and then the effects of that on him are increasing. So it changes over time. So I just, you know, my view is if we can have a more flexible system, or one that, you know, is accessible for everybody, at whatever stage they're at, then, you know, it's better for everybody.
Yeah, absolutely. I'll just ask if anyone else in the panel would like to comment on that issue before I go to another comment in the chat. So I don't know, Ross or Claire, you seem to be particularly nodding as Belinda was speaking.
I think, sorry, Belinda's story resonates with a lot that come across our desk of mothers in particular that have been the primary caregiver or the sole navigator of what is a complex and almost unintelligible system to some degree, because you can't remember where you're up to in the various referrals and mechanisms, and they don't seem to be interrelated quite easily to an outsider. So the same thing happens to people with spinal cord injury who recover to a certain degree, and then they have challenges with the NDIS saying, well, you no longer require NDIS supports, we'll just cut them all. So, and it's a valuable thing for you to reflect on right now in your life, Belinda, that there's some support needed to prepare Dylan to be supported into the future. So I congratulate you on that, but it's no less traumatic. Trying to navigate a complex system. It's something we come across a lot.
Claire, was there anything you wanted to add?
Yeah.
Obviously, working for a system that does support people long term.
Yeah, I echo everything Ross said as well, and it's a hard road and journey for you too, Belinda. And I think it's an ever-changing. The NDIS is relatively new to us, but it's a really hard system, and it's since its inception in Queensland, it's part of our role as rehab coordinators in ABIOS has really taken, the NDIS has taken over, and we get confused by it. We're health practitioners, and we help. A lot of our role is trying to help people, and like your son as well, to try and access the services that they need, and they change their rules and their systems regularly. But I might be able to, if you'd like to reach out separately, we could maybe have a further discussion, because I think we're running out a little bit of time, but we may be able, our service may be able to help you if you'd like, and your son. Yeah.
I would love that.
Yeah, maybe. I think my manager's
to the Hopkins Hour.
I'll accept it gratefully.
Thank you, guys. That actually taps into a comment of Christina's, actually, where she said this research is very helpful. How do you share this knowledge within Queensland to professionals supporting patients with brain injury? So, Christina, I assume you're saying that you're interested in getting either some of the resources that we've spoken about today, or possibly even some of the papers or outputs that we're in the process of writing. So, Kelsey has published a number of papers on the Dignity Project, and there is a paper under review on the self-advocacy research. So we will be looking to disseminate that if and when it gets accepted for publication. But please do reach out to us, Christina, if there's something in particular that you're referring to today that you feel would be helpful knowledge to share with your colleagues, or ask us to come and do a presentation and chat directly to your service. Is another thought. So I think a question that would be good to end on today is our final question. What is the impact of championing self-advocacy and dignity? And Jessie, I haven't asked for your input. So why do you think it matters? Why is it so important, and what impact can it have?
I think that as you ask that question, I think I'm reminded that, you know, as people transition post-injury and kind of become aware of who they are, what they want, and the care landscape, as Ross mentioned, it's a difficult one to navigate. I think, you know, even if people aren't ready to take on some of those self-advocacy roles straight away, the knowledge that they have that option empowers them and makes them feel as though that's a choice that they get to make and that's something that they can build up and work towards or come back to at a later stage. And I think, just giving people the choice in their care, whether that's the choice to have a say in their care or the choice of the type of care that they get, is so valuable. And people, just spoke about the relationships in the interviews that we conducted, the relationships they built with clinicians and how important that was, that emotional support and that advocacy on that behalf, but also that support to self-advocate was, in terms of giving them back a sense of self and helping them to develop their own personalised goals moving forward.
And we've also seen how self-advocacy skills can turn into advocacy skills more generally. And Ross, you mentioned that people can become an ambassador for others almost by learning those skills and realising that this is an opportunity to transform services, access and systems and create a legacy that benefits others. And that feeds right back into sense of self and identity as well.
Yeah, and I think that's why we try and demonstrate to people that they can amplify their efforts and almost create a legacy, which has a direct positive impact on their sense of resilience and sense of self, and a tick box in the dignity checklist, if you like, because once you've demonstrated that you can overcome an obstacle, other people have been there, other people are right there right now, and you can, if you encourage people to reflect on, do you think this might help others? And all of a sudden they go, yes, I can, even in my new journey, even on my new uncharted future, I can help. And we all love to be not only seen to be helping, but actually helping others. So it's something that we love to do, to see whoever's ready at their stage to amplify their efforts into something that can be become statewide or even national. Yeah. So the impact of overcoming a single challenge can actually lead to societal change.
Yeah, be very powerful. Kelsey, I'm going to give you the last word before closing. For you, what is the impact of championing dignity?
Thanks, Tamara. I think for me, there's such an important holistic individual impact that we often forget about in research, or you can gloss over in the focus of all of the changes that need to be made at a system or service level. But at the end of the day, there's an individual, as Belinda's so eloquently shared. There's a person and their support network and family. And so even just providing that dignified and self-advocacy experiences for that one person has such a lasting impact for them. And then, as Jessie and Ross both mentioned, there's of course that snowball effect at a community level through then increased levels of peer support, increased advocacy, increasing the accessibility and inclusion of systems, and kind of paving the way for other people. And I think just having that holistic drive to ensure that there's dignity and self-advocacy within system interfaces helps our attitudes. It changes attitudes. It changes the perception of what's possible. And then, of course, the attitudes inform how we design and deliver services and spaces, and making sure that they're accessible and inclusive. And then that, of course, affects attitudes again. So it becomes this really nice continuum where we're just making sure that people with disability are included, and that the systems and services are universal in their coverage of individual experience. And that individual is at the heart of everything that we do.
Well said. Thank you, Kelsey. We have gone over time, so thank you so much, everyone, for allowing us. I think it's something we could talk about all day very easily. It's such an important and impactful area of focus, self-advocacy and dignity. So I would like to very much thank our wonderful presenters, the 3 presentations earlier today, all of which will be available, the slides, if there were slides, and also particularly thank Belinda and Claire for joining us for the panel discussion and such a very thought-provoking series of comments. I believe I really liked what you said, Ross. It's life as you imagine it, not as we imagine it, and that focus on the individual empowerment coaching, scaffolded support. There's just themes that are running through my mind that are the nuggets from today. So thank you very much to all of our attendees, and please feel free to follow up and get in touch with our presenters and contact the Hopkins Centre to request any of the documents that we showed today. And of course, we have the recording available as well. Thanks so much, everyone, for your attendance, and have a wonderful week. Thanks.
Thank you.